All right, welcome fellows from the East Coast, West Coast, and around the world. This is our first ASMBS Fellow project for the Fellow class of 2024-2025. My name is Dr. Shaina Eckhouse. I am at Duke University as an associate professor, and I'm on the Bariatric Surgery Training Committee as the chair of the committee. I'm joined by Dr. Rickesha Wilson, who is an assistant professor at Cleveland Clinic, and we will be your morning moderators for the East Coast. And then our West Coast colleagues will have moderators at 3 p.m. Eastern today. We are going to have a few housekeeping things to get you up and going, and we'll make announcements kind of for the future through ASMBS, so you know what's coming up. We have a bariatric happy hour focused on our trainees as well, and our next one is August 22nd at 8 p.m. If you want to volunteer to do a presentation, please reach out to either myself or Dr. Faiz Sharif and the Bariatric Surgery Training Committee. The goal here is more of a article review or journal club. ASMBS weekend is coming up November 7th through 9th. It is in Atlanta at the Marriott Marquis. Abstract submission guidelines will be coming out soon, so keep your eyes peeled to submit your research from your either residency or fellow year. And then this is important because of our bariatric certification. So ASMBS offers a fellow certification, which requires you to do a certain number of anastomotic, non-anastomotic cases, emergency cases, and endoscopic cases, and clinic evaluations and inpatient evaluations. Please make sure to check out that website, which is through our ASMBS, and I can share in our chat today so that you can look at the requirements. It is easier to keep them up to date as you go than have to fight and find all the data for your requirements at the end of the year. So stay up to date on that. And one of the important parts is doing research. And so this is where ASMBS weekend and ASMBS annual meeting can be a good place to present your research. And then lastly, as of, I think a couple of days ago or a couple weeks ago, our ASMBS Learning Management System went live, which is a maintenance of certification repository for different articles from SWORD and our annual meeting presentations that you can go back and get not only CME credit, but learn about certain topics if needed to help with cases or patient management, or just to make sure you get all the CME you need to maintain your board certification and licensure. On that note, we will move on to our presentation of the day. And so in honor of Dr. Jane Spangler and the hard work she's done, we have always had the first talk of the year come from our immediate past president, who this last year is Dr. Marina Kurian, who was our ASMBS president from 2023 to 2024. She is a clinical professor of surgery at the Department of Surgery at NYU in New York, and has been a leader in understanding kind of how obesity medicine and bariatric surgery work together. She unfortunately is not able to be with us live today, but she did give us a video that we will watch, and then Dr. Rickesha Wilson and I will answer your questions as they come up at the end, and we'll have a discussion about what she talks about. The focus will be on the future of bariatric surgery. Thank y'all for participating, and we look forward to a great year.
All right, you guys. I'm Dr. Marina Kurian, and I am the immediate past president of the ASMBS. It also could be said that I am the first has-been. Just joking. But anyway, I wanted to share with you some of my thoughts on the future of bariatric surgery. But first, I wanted to tell you a little bit about ASMBS because some of you are new to it. I do believe we are the premier metabolic and bariatric surgery society in the world, as well as certainly the one that represents the most for both our patients as well as for people who participate in bariatric surgery. I am so excited that you guys are here and that I'm lucky to be the first presenter for your fellows curriculum. And I wanted to let you know that our fellows curriculum at ASMBS is so full of rich detail, experiences, and just so much knowledge. And it has a lot to do with the Bariatric Surgery Training Committee that initially was under the auspices of so many people, but I know that Corey McBride Aguilar did a lot for this, and currently Adrian Dan, Kanur Jane Spangler, and Shaina Eckhouse, as well as the rest of the committee, have really worked so hard on trying to get everything ready for you guys. And there's so many eager members, as you can tell from the Bariatric Happy Hour and all the other sessions that they hold, they're really just so committed to getting you guys the best information so you can take care of patients in the best possible way. Okay, so the future of bariatric surgery. I'm going to go into a lot of like a story, really, because it's not simple, it's not clear, it's a knowledge, but it's a belief as well. So I'm going to craft the story, and hopefully we'll all go together. These are my disclosures. I do speak for several companies, including some of the medication companies. I'm going to be talking about endoscopy, medications, and some of the other newer procedures that we have for bariatrics. I'm trying to tell you some of what I'm doing. Everything is here. This is OAGB. I don't do any of it. This 0% is actually endo. I'm not sure why it doesn't show up on this slide, but I am trained in advanced endoscopy, and I have done ESG revisions, and I currently do not do them for a variety of reasons. I also have my obesity medicine boards, and because of that, I do a lot of medication in my post-surgery patients, as well as some preoperative or some just medical weight loss patients as well. And because of my comfort level with that, it has decreased some of my revisions that I would do for weight recurrence significantly. When we're talking about bariatric surgery, we have to look at where we are now. So obesity rates are still climbing in this country. We in 2022 updated our guidelines for BMI, and what happened is that basically now BMI 35 instead of 40 without any obesity-related health conditions, and then 30 to 35 with obesity-related health conditions are also included in the groups that we know benefit from surgery. At the same time as we did that, GLP-1s just skyrocketed, right? Like, I know everybody has that knowledge because you either know someone who's on a GLP-1 or you know someone from Insta or from, celebrities that are taking it as well. And what happens is that they also experience more than 15% total body weight loss, and there are going to be some other medications that are coming that will actually give us even closer to 25% total body weight loss. Surgery can get you up over 40% total body weight loss, and so that's where our differences lie. But then there's a lot of discussion right now about whether these injectables are actually too expensive. There used to be discussion about how bariatric surgery was so expensive, and but there's also studies to show that the cost of the surgery is amortized over 3 years, and so you're kind of making the money back at that point between reduction in medications and overall health benefits when we're looking at it just from an insurance standpoint. But if you look at improvements in comorbidities in patients' mobility and their decrease in sick days, et cetera, the overall benefit to our society is far greater than the cost of the surgery in that one time point. So the next thing is the medications, though. There has been a study from Novo Nordisk that looked at semaglutide and gave it to the patients for 1 year, and then they also looked to see what happens in the second year when they come off the medication to see how their weight loss was, and basically about 2/3 of the weight they lost by the end of the year was regained. So on the medication for 1 year, and then 2/3 on the second year when they were off meds, they regained 2/3 of what they lost. when we look at bariatric surgery numbers, you could see what they were in 2021. In 2022, we got a lot closer to 270, but it was only about a 1% growth. And 2023 numbers will be coming out in the last quarter. And I think that they're going to look very different. I speak to my colleagues across the country often, and I'll say some of them say they're busier, some say they never drop their volume, and others have lost 10 to 30% of their bariatric surgery volume because of the medications, the GLP-1s. In this country also, which I do not agree with, there is compounding of these drugs. That is not the actual drugs. And the thing about these GLP-1s that are out there, all under patent. So the people who are making this are not actually getting the patented molecule. They're getting something that's a approximation. And so I have never prescribed a compounded medication to my patient because I don't believe in it. I don't think that that's the appropriate way to treat them. Anyway, so in 2023, I think that we're going to see that the numbers may go down, and we'll find out in the last quarter. It's impossible for any surgical resident to not have heard that bariatric surgery improves all of the obesity-related health conditions, right? And so as you fellows, I'm not telling you anything new, but I want you to think about numbers. So for major adverse cardiovascular reduction, okay, Ali Aminian, a friend and colleague, has really published extensively on outcomes in patients and their obesity-related health conditions. So he found that metabolic and bariatric surgery results in 40% reduction in MACE. There's many other articles that talk about diabetes remission, improvement in kidney disease, improvement in osteoarthritis, sleep apnea, MAFLD. So between all of that, bariatric surgery does a lot of great things for every health condition and every organ system that a patient has. What's not clear to the public, and unfortunately to our physician colleagues as well as other providers, is that metabolic and bariatric surgery is super safe, and we are also, changing dramatically the health of our patients. And that's something that we need to get out there more often and have all of these, numbers really at our side. So when we're talking to our colleagues, like, for example, Novo Nordisk, semaglutide, improves MACE by 20%. And so we could say, at the same point, be like, semaglutide's great, GLP-1s are great, and we know that it helps cardiovascular outcomes, but bariatric surgery actually does it twice as much because we get greater weight loss. I want to show you here also the GLP-1s. They're looking at it, not just for glycemic control, but here for lipid lowering. And this is also something that bariatric surgery does super well in improving significantly hyperlipidemia as well as other conditions. And then, I've had an interest in MASH and MAFLD. They've changed it, guys. It's not NASH anymore, MASH. Metabolic dysfunction associated steatohepatitis, and it's also MAFLD. So now, surgery actually can improve MASH and MAFLD. It can also even reverse cirrhosis sometimes. Not in every patient, but it can. And what we're seeing here is that they're trying to pinpoint that tirzepatide, which is a dual peptide agonist, can markedly reduce the MASH-related biomarkers, which is also what surgery does. But I don't have it in this slide set, but I do have that patients who had metabolic and bariatric surgery, there are studies that show that the greater the weight loss, the greater the reduction in cancer risk to these patients. So if you have medications that take 15 to 25% total body weight loss down, that's great. That's an improvement in cancer risk. But if you have procedures that can take patients down 40% total body weight loss when they have it, this will actually result in greater improvement in their comorbid conditions. Now, this is not a surgery only or medication only. I think that there's actually a lot of synergy in including them, and we may actually ultimately end up changing the paradigm of obesity treatment as well as severe obesity treatment, because if we combine them, we may have something super powerful that will actually normalize BMIs and give maximum reduction of these patients' health-related outcomes related to their obesity. I want to tell you a little bit of cost. I'm not sure how much you guys have been exposed to the costs of obesity medications, but when you look down toward the bottom of this, you look at the GLP-1s. They have a significant cost per month if it's not covered by insurance, and also if the patient has to pay for it. Even if they have a coupon card or whatever, it's still going to be at least $500 or more. And when you think about this, and as I talked about the cost of surgery, which is a one-time event amortized over 3 years in some studies to show that insurance companies will get that ROI at 3 years, these patients are on monthly at least $1,000. So it's and from that one study that I already mentioned to you guys, they're going to have to continue to take it. So there's a significant cost associated with these medications, and there's other issues as well as supply, as well as making sure that patients can tolerate it. And also, some patients do not do well on the drugs because of side effects or because they're not actually losing as much weight. So there's an opportunity ultimately when patients realize that the medications are lifelong and or that they can't tolerate it or they haven't achieved the success that they wanted, that they will actually turn toward metabolic and bariatric surgery, and ultimately our numbers will grow. And we expect that to start happening either 2024, 25, maybe even 2026. We should hopefully increase the overall number of patients that we treat from that previous 1.4% to greater. In the mix also are endoscopic procedures, and so here I have the balloons that are approved, Orbera, the Schatz. Ellipse is not yet, but it's been submitted. And then we also have the Apollo Overstitch device, which has been approved for tissue approximation endoscopically. And with that, it's the endoscopic sleeve gastroplasty. I'm sorry, I put gastrectomy. It's endoscopic sleeve gastroplasty, which actually is less like a sleeve in the current iteration. It is more like a VBG because they leave the fundus and they kind of tighten it in the mid-body to the incisura. And those results are also available. I don't think I have the MERIT trial up there, but the MERIT trial came up to about 14% total body weight loss at a year, and this was a well-done multi-center study about ESG, endoscopic sleeve gastroplasty. The next is showing you things that have been in the past. The transpyloric shuttle I thought would be better than the balloon because it toggles back and forth and allows better emptying. Unfortunately, even though it was FDA approved, it has not come to market. And then the full stents device is actually created by a bariatric surgeon, and Randy worked on this, but this has also not come to market at this time, and it was more as a stent. But it just shows you that people are thinking about the endoscopic space and what else they can do. Some of the things that are coming up and the future of bariatric surgery is things like the Bari clip. I know some of you, and I don't have a picture of the Bari clip actually, but the Bari clip is applied from the greater curve around the level just off the incisura up to the angle of His. And it has areas where the excluded stomach can empty, and there's multi-center trials that are going to be coming up. for this. And the Bari clip, you might think, oh, it's a foreign body, it's like the lap band, and I still do some lap band. I probably do 2 to 4 a year, and it does work in some people, but it's not for everyone. And I think the concept that we have to start thinking about, as I said before, it's not an exclusion, but if we do something that's a simpler procedure, like a Bari clip or a lap band, and we add medication, can we get the same level of weight loss as we do if we do a gastric bypass or a SADI? Magnets. There are 2 companies currently, and I'm sure there's going to be more, that we're doing endoscopic anastomoses, and I'm going to talk about that in the next slides. And then bitransit partition is another procedure that's partly related to the magnets, but also being done surgically right now, that I think has a lot of value, and I look forward to seeing more of that data because I think it can help with the reduction in the obesity-related comorbidities, but as well be less malabsorptive and decrease some of the complications that we see with malnutrition. So endoscopic anastomoses, this is actually from Chris Thompson's group, and originally the plan was to do this purely endoscopically, put a magnet down from the stomach into the proximal intestine, and then work your way all through the colon and get into the small bowel and drop another magnet in the ileum. This is something that Chris Thompson can do very well. He's very talented endoscopist, advanced GI doctor, but not everybody can do this. So ultimately, this and the other magnet system have a laparoscopic component to introduce the magnet in the ileum, and the endoscopic part for the upper part of the anastomosis is intact. What happens is the 2 magnets meet, and there's pressure necrosis of the tissue, and then what you see is that you get these anastomoses that form. And what happens here, if you think about this, is that the bowel's going like this. There's this is all the bowel here, but these 2 magnets meet, so that's why you have this double lumen. One is native, and the one is going to be in the other. So they had done, 10 patients, and the weight loss for this was, the total body weight loss at 6 months was 10%. It would probably went up to about 15 at 12 months. But the thing about doing these duodenal to ileal anastomoses is that you're not going to have weight loss stop at a year. You will see further weight loss if you follow the patients longer. And I think that this was actually a very interesting study. And then the next one is the other company. So the first company, Chris Thompson's, is GI Windows, and this is GT Metabolics, and this is Michelle Gagne. And similarly, these magnets are introduced. There's, in this version, you don't make a hole in the small bowel, you just move the magnet through the intestine to where you want it to be, and then endoscopically place the magnet in the duodenum, and then you make that connection right here. And then this is just showing you, again, the endoscopic view where you have double lumen. And this was their study of their animal studies showing how this anastomoses were quite well done. And so when they occlude like that, and since both of these are being done laparoscopically, you can actually make sure that the mesentery is not opposed to the other area. So you know it's bowel to bowel, and that will actually decrease the bleeding or any other risk because it's just necrosis and it heals very well. I'm going to go a little bit off-piste with the next one because this is also just showing you how people are thinking in the endoscopic space and about the possibilities that are out there. This is duodenal mucosal resurfacing, and what we are seeing is that if they ablate the duodenal mucosa, you can actually repopulate the cells and change the trajectory of diabetes. Okay? So the idea is that the Western diet, fat and sugar, it's like they know me or something, I'm not sure, but anyway. And then it goes to mucosal hypertrophy and changes in the gut hormones, resulting in end organ effects on the liver and muscle, decompensation of beta cells, and resulting in hyperglycemia. So if we can change that by doing something in the mucosa of the gut, then we can actually affect diabetes. So this is really originally for diabetes. What happened at 3 months? Now they're following these patients. I don't have the newest data, but this was done actually more than a couple of years ago. But you saw at 3 months the A1C dropped. If the average was 9.3, then it dropped down to 8.3. That's pretty significant at 3 months. And they also happen to have more than 15 pounds of weight loss. But again, the data is just showing you what are the possibilities that we can do to improve patients' health-related comorbidities and how we can do it. This is just talking a little bit about this. It just shows you all the endoscopic possibilities, and I put an X to show you what's around. The reshape is gone, Obalon is gone. Some of these are casualties of COVID, but some are also related to what the findings were, or just looking at the market space for balloons, which in our country is not so high, but it is there. The transpyloric shuttle, it was FDA approved, but it is shelved, basically. The company did not continue with that. And the Aspirosys was also an interesting thing. Basically, it was a G-tube that allowed partial emptying of what you ate. It just did not have the numbers to continue. Bipartition, this is just an idea of one. And these are not being done in this country, but they are being done around the world. Do the sleeve, hook up a loop to the stomach. Oh, I don't know if I can go back. I don't think I can. But anyway, in the bipartition, you can also do that bipartition from the duodenum to the jejunum, or from the jejunum to the duodenum to the ileum, or from the jejunum to the ileum once the sleeve is done. And that bipartition allows food to go two ways, or in some cases, and this is what needs to be studied, actually, there's so many great things that we can look at, is what percentage goes one way versus the other. And it's going to vary from patient to patient. But because the food is going two ways, some of it going through the native anatomy, the impact on malnutrition is less, right? Because we're feeding both ways. But there's still enough with that duodenal ileal or gastroileal anastomoses that there is weight loss. There's still some gut hormone changes that allow for improvements in diabetes, etc. Now, we need to study that in more detail, but that will be coming. This brings me to some of what I brought up before, which is looking at metabolic and bariatric surgery and how it fits in the paradigm of a chronic disease that we treat called obesity. We have chronic disease models already, right? We do it for cardiovascular disease, cancer, osteoarthritis. You guys don't think that's chronic? Totally is, right? Like, you have a patient who has knee pain, primary care doctor is going to put them on some medication. Why don't you take some Advil, etc., right? Then they go see somebody. Sports medicine ortho, you're on Celebrex, see how it does. It doesn't get better. You might need injections in your knee. You might need an arthroscopy to get it cleaned out. then at some point, you're still on those meds, because you have to take them every day, otherwise you can't walk. And you're also now being considered for a knee replacement or a hip replacement. Once you have that, you know, things might be fine. You're still taking your medication. You had a procedure, or you had, you know, injections, and then you had the clean out, and then you had the replacements. You've had procedures, and then you have medication still, always still on meds, because you still have knee pain, but you're able to walk. When you think of what happens in ortho, you could also say that for cardiovascular disease. You have hypertension, you're on meds, you have some cholesterol, you're on meds. Sometimes you need to be on 2 or 3 meds for each of those conditions. Then something happens, you might need a stent. Then you need more stents. Then you might need a cabbage, right? At no point in the history of this whole disease process of cardiovascular disease, of osteoarthritis, I'm not even going to talk about cancer. At no point does anyone question the medications that the patients are on or the fact that they need multiple procedures. Because why? Because we're treating chronic disease. We need to not convince, but explain to our colleagues who are seeing all of these patients, and as well explain to patients, that this is very similar to what happens in other chronic disease models. Meaning, and I have a patient I've operated on, and they like me, so they come back and see me, and they're like, you know, I gained some weight. I'm like, yeah, okay, so let's, you know, re-engage diet and exercise, but I want to put you on some meds. They're like, you know, can't you just reoperate on me? Which is why we have all those endoscopic revisions and things like that. You know, reduction in, I'm going to get into that in a little bit, but like patients like, can't you do something, another procedure to me? I don't really want to take meds. And this is when I'm like, well, if you had high blood pressure and you were on medication and then you needed, or you had cholesterol and then you needed a stent, would they take you off your cholesterol medicine? They're like, no, it wouldn't happen. I'd still be on it. So similarly, I'm trying to convince the patients, and they're at fault too. They're not like, hey, you know, they don't get it. They don't see how obesity is chronic. They still think it's something they did, and that I can fix it and make them eat less, and then they'll be fine. And we all need to move away from that and realize that everything can be done in concert, and in many times they need to be there and done together, medications and surgery, to really provide that synergy, which is important for resolution of all the obesity-related health conditions and ultimately improve patients' lives and outcomes. So, chronic disease model again, medication first, minor procedure, major procedure, revisional procedure, continuous. We face a lot of obesity stigma and bias in this country, and actually around the world. It is still felt like that this is obesity is a disease of willpower and not an actual disease, but it is a chronic disease. And there are in this country one and done insurance policies. You can have one bariatric procedure and that's it. Or, you know, there are many policies that don't allow any obesity-related procedures or obesity-related meds. They don't allow the treatment of obesity, which is such incredible bias. And actually, our current president, Ann Rogers, that is her theme, is to reduce the stigma and bias against obesity for her year. So we have a lot of uphill battles. And part of the reason I want you to start thinking about this, and one of the things that will come out hopefully in the fall, which is coming up soon, golly, that's crazy. It's almost the fall. But we're going to try and put together like talking points when we meet with our colleagues or friends to really highlight what bariatric surgery does. But our failure perception is related to we have complications. We actually have less complications even than laparoscopic cholecystectomy, if you can imagine, in terms of mortality and in terms of it's safer to do bariatric surgery in terms of mortality than with laparoscopic cholecystectomy. So we also have acute complications and chronic complications, and I think the majority of our patients do very, very well, and unfortunately some do have complications. It's a smaller percentage, but we also have to face that concept that our patients may have had inadequate weight loss or they have weight recurrence. And this is where, you know, you'll talk to a colleague and they'll be like, oh yeah, I saw that patient, but did you know they regained a lot of weight? And my point to them is always like, send them back to their surgeon, send them back to me, you know, let me help them get back on track, because we're not trying to be separate. We're trying to work with the primary care doctor, the patient, and also for me, it's my accountability. I want the patient to do well. So actually have my obesity medicine boards, because I know that the patients that are having these surgeries need to actually, you know, be monitored and may need medication. And also it's looked at as, you know, we spent so much money, as I mentioned before, you know, right at the inception, and now how is it going to be amortized? Guys, no one's amortizing the cost of a knee replacement, or no one's amortizing the cost of a cabbage, you know? And so this again speaks to that bias that's out there against the treatment of obesity. I want to talk a little bit about, you know, endoscopic aspects of metabolic and bariatric surgery, but again, this speaks to really identifying some of the issues, right? This was a study that said 41% of patients after 10 years after bypass regained some weight. And no surprise, the younger you were, the more likely you were going to regain weight at some point, because, you know, it's, if you have 40 years versus 60 to 80 years, you know, of your life left, you know, what's going to happen. And we're treating a chronic disease. So this was just a study showing that weight recurrence happens, and this is a study from Bipin Chand, and they looked at what's up, and we called it technical failure. So is it a technical failure, or is it just really the way the body heals? And you know, our surgery didn't fail. This is just the body kind of adapting to our procedure. So in this gastric bypass patients, they had, this is like Goldilocks, the pouch was too big, the stoma was too big, and then both happened, you know, and actually this speaks to some of the endoscopic things that we've done to try and address this. And I bring up this aspect, particularly in gastric bypass, but it also is applicable to sleeve and volume reduction of the sleeve, because we need to consider this chronic disease model where we may have to tweak something with surgery, but also consider our own use of terms such as technical failure, because this is just, you know, many times this is just how the patient has healed. This is some of the endoscopic things that have been done in the past. The stoma fix was used to do the Rose procedure, which was a reduction in the size of the pouch. Currently, I call it Tori, but they say Tor. I don't know why they have the E. They could just, you know, T-O-R works. But anyway, Tori, and this was a study looking at interrupted purse string versus double purse string, where they would go in and suture around the gastrojejunectomy to decrease the size, and what they found is they had up to 24% excess weight loss. And a quick way, if the BMIs are over 40, to sort of guess what's going to be total body weight loss with excess is just to cut that excess weight loss in half. So about 12% total body weight loss was found in this study. You know, and one thing also when we talk about, well, anyway, let me go with this. There are other ways to reduce the size of that gastrojejunectomy, and we've always tried to do it endoscopically versus going back in. And why? Because the risk of a redo or a revision, we always like to say, is 3 times the risk, right? So if the risk of leak is, you know, 1% or less, then the risk with a revision is 3%. So if you can do something endoscopically that can help, then that's great. But historically, all the endoscopic methods have been more repeatable because they weren't durable. So repeatable because they weren't durable. So, but this is just talking about a simple procedure, again, endoscopic, to reduce the stoma size, and they actually had very good results, 80% reduction in the weight that was regained. And when you look at this study, which was from Chris Thompson's group, they saw 8.8% total body weight loss at 1 year after they did the Tori procedure. And in essence, you know, this 8.8%, is part of the reason I actually stopped doing the endoscopic reduction is because I could also medicate the patients and get something similar in terms of weight loss or greater, because if you can get them on a GLP-1, we have to consider in the future that endoscopy is going to be a big deal. As a tidbit from our past, sleeve leaks have been some of the worst leaks to deal with for a variety of reasons, including the higher pressure nature of the sleeve. And obviously in an unstable patient, we're going to the OR, right? That's like, it's not an A, but you know, it's go time. But in patients that are relatively stable, we used to go and take them to the OR, which could be a lot of things. It's stressful for the patient. It's another operation, another, some tissue trauma. It's also stress for you. It's a lot of things that are going on. This was, originally done in France, and we've all embraced this as in the stable patient or relatively stable patient to go in and do an endoscopic drainage of the leak with double pigtails. And it has really changed what we do and also decreased pain for the patients, improved their mobility, improved their opportunity to actually leave the hospital and go home and not have to stay. So this has actually been a real boon, and it's a great, if you look into this from us doing operations, et cetera, and now also people stent as well, but really this was a culmination of efforts to ultimately say, hey, we embraced surgery as the primary, but then there was a complication. We used endoscopic techniques to try and improve patient comfort and outcomes, and ultimately it worked for us too. This is a ASGE statement on endoscopic therapies, and basically, we can do this. Here we go. Accredited gastroenterology fellowships or general surgery residency. You guys all did FES. You guys have worked hard doing and getting your endoscopic numbers. This is definitely something that we need to be doing, and I have done in the past. I currently am not, but I put in a bunch of balloons, etc. I mean, that's a different discussion. But I want to be there when something good comes out. And one of the things, or some of the things that are going to come out are endoscopic robots, and I'll talk about that in a second, I hope. So this is what we look for when we say we want a new endoscopic bariatric therapy, at least 25% excess weight loss at 12 months. That's at least 12% total body weight loss. That it should have had a significant difference of 15% excess weight loss between the control group and the one that received the endoscopic bariatric therapy, have a very low SAE, less than 5%, and have an impact on at least one obesity-related comorbidity. You guys, in the future, we're going to do surgery. We're going to do more primary bariatric procedures, but you're also going to see a lot of revisions, and you also need to be familiar with some of the endoscopic therapies, because I think they're going to impact and bring more patients in that will receive treatment. And so this is definitely something that you have to do. So now this field and talking about the future of bariatric surgery, it's completely an evolving field. We operate and do SADI, single anastomosis duodenal ileostomy, as a primary or as a revisional procedure. OAGB has been approved by the ASMBS as well, and there are some of our colleagues are using that as a revision procedure as well as primary. And once we start getting the magnets up and running, and those trials are coming, that will also be part. That's why I'm saying it's really a field that's changing, and that these magnets could create a bipartition SADI or a bipartition SASI, which is stomach to ileal anastomosis. And so we may be seeing, a sleeve as a revision of a sleeve, or even a primary using the magnets as well. There are also some newer endoscopic trials on a automatic suturing endoscopically that leaves like rows of sutures, and so plicates the stomach multiply, creating the same effect as a endoscopic sleeve gastroplasty. That's actually easier to use than suturing, grabbing tissue and suturing. It kind of sucks in the tissue and fires this thing through. It's kind of cool. It is novel. I don't have pictures of it, but it is something that's going to be much easier, that will actually increase the acceptance of endoscopic treatments, because it's going to be much easier to use that device. Don't forget about surgery and medications. Like if we did a bari clip, or if we did a sleeve, if we partner it with a strong drugs that's either a single or double peptide GLP-1 receptor agonist, we may actually see results equivalent to patient having a SADI, with a sleeve. And I think that here in the US, we're definitely looking at all of the options for these surgeries, and that's the beauty of having MBS AQUIP, where we can actually collect this information and see how patients are doing. And I think our future in metabolic and bariatric surgery is really bright. We're not done. We are so ready to increase and embrace everything else that is allowing us to grow the patients that we can treat. Currently, we treat under 1% of the patients who qualify, and I hope that in the next few years we can even grow to 2 to 3%. I think that we absolutely have the surgical capacity and endoscopic capacity to do that. But we want to maximize what our patients can achieve while maintaining their safety and improving their overall outcomes. Anyway, I have been honored to give you this talk. I hope that you found it intriguing, but it's really a very long story, and it's still ongoing. It might be the never-ending story. Anyway, thank you so much, guys, and I hope the rest of the year is fantastic for you, and I hope to meet you guys in person.
Thank you all very much for listening in. I apologize for our technical difficulties, but let me pass it over to Dr. Keisha Wilson to start the conversation.
Yeah, absolutely. So excited for the new year, and certainly appreciate the lecture and everything it covered by our immediate past president, Dr. Kurian. So, some things that, just some notes that I took just in general, keeping kind of the future and where we are in bariatric surgery in mind, and you starting on your fellowship journey. And mind you, just maybe 3 years ago, I was just finishing my fellowship in 2021. And so many of us on committees and in leadership are not far removed, and we certainly care about your journey and kind of where you are. So one of the first questions I had, and just given the current culture we're in, is just to kind of pose and get thoughts on is, you can't talk about the future without talking about medications and how they're impacting everyone's practice. So the first question is, should you get certified? Is this in obesity medicine? Is this something as a metabolic surgery fellow or having that as a component in your fellowship? Should that be a priority for you to think about finishing up your fellowship or in the future in practice? And so I'm happy to get the opinions and thoughts of my colleagues. I don't have my obesity medicine board certification, really due to kind of timing and trying to juggle clinical responsibilities and academic pursuits. But I really do think it's a great thing to consider, especially because depending on what job you might get, a lot of jobs on the market might look different than what you've anticipated or what you've seen your mentors develop. But I think having your board certification can make you marketable, can help you add value to whatever practice that you join. And so in a practice like mine, we have obesity medicine colleagues that we kind of refer, but not every practice is like that. So I would strongly consider adding that to your toolbox so that you can add value and be ready to do that for your patients and for whatever practice you might join.
I really appreciate that thought process, Dr. Wilson. So in full transparency, I do have my obesity medicine board certification. I got it my third year, I think my second or third year out. Trying to remember what year it was. Anyways, and I've been using it ever since. And I think you're kind of spot on with it for a couple different reasons. I do think it's beneficial. Number one, if you do it closer to graduation from fellowship, you can use your fellowship training as the criteria or your like prerequisites to sit for the board certification. So it's easier to plan for it now that, or at least in the first 3 or 4 years. And it is if you're 10, 20 years out. So taking advantage of it now may be helpful. I think it's beneficial for a couple different reasons, kind of no matter what practice you go into personally. I work at a large academic center like Dr. Wilson. I do have obesity medicine board specialists, and I also practice obesity medicine management like Dr. Kurian does, where I use it a lot in revisional patients. And in fact, there was some data presented from Europe at ASMBS this June that shows the benefits of it for weight recurrence and the efficacy with lower risk compared to revisional surgery for weight recurrence in certain situations. And so it can be a really nice first step where an obesity medicine provider without a surgical background may not feel as comfortable for our weight recurrence patients. The other place is if you don't have obesity medicine specialists in your institution, to Dr. Wilson's point, then you can start to practice it and you become more marketable. But I think even more importantly, it's making sure we're able to sit at the table long-term regarding obesity and be part of the program and the discussion. There are 80 plus medications currently undergoing FDA evaluation and R&D development that will be coming out in the next 10 years. And these medications that are quite expensive now will not be expensive in the future. They will continue to improve in efficacy. Does not replace surgery. It means we have a better armamentarium to treat obesity as a disease. And I think making sure that we're ready to talk about all these medications and how that interacts in our practice as surgeons treating a medical condition is really important for our own future and kind of future as physicians and as surgeons focused on obesity. Dr. Dan, who our immediate past chair of the Bariatric Surgery and Training Committee, our emeritus, if you will, our guru, it also recommends getting your focus practice designation. So in, I guess, brutal honesty, I also have that. I write questions for the focus practice designation, so I had to get it, and I was excited to get it done. If you do your bariatric surgery training, the FPD will be a cakewalk for you with little need to study after your fellowship. And it adds credibility to your training, and patients can look it up and feel even more comfortable and confident in your skill set. So I would agree, those both are really helpful. curious what your thoughts were, Dr. Wilson. I'd love if you, in the last 2 minutes, I was going to focus on the two surgeries that we're not currently doing in the United States, or two kind of ideas or techniques, the bipartition and the magnets. And realizing you may see more international patients than we do at Duke, coming from Cleveland Clinic, with how big of a referral pattern you have internationally. Have you started to see any of those in your practice? And if so, kind of how are you guys discussing it at your institution?
Yeah, the some of the new magnetic techniques we haven't started to adopt, but we do have an innovations team and kind of a pathway to introduce some of those newer techniques into our practice. And I'll kind of piggyback. I've enjoyed learning about these at the meetings, and really, this is just a plug for fellows to think about this. Really participate in organizations and committees. I mean, this will help you stay in the forefront of what's going on in terms of new techniques. And a note that I wrote during the lecture is something that I've been able to carry with me as a fellow. Just be thinking, whatever you learn as a fellow is not law, it's a launching pad. Okay. And so there are always going to be new techniques and changes and guidelines and standards. And so I think it's imperative that we all kind of stay ready and malleable enough to incorporate new techniques into our practice. And so in terms of the bipartition and the magnets, I think it's wonderful. I have not incorporated those things. We don't do those by and large yet at Cleveland Clinic, but I think a lot of these newer techniques and practices, I think it's a matter of our interest, our education, and our willingness to learn and connect with those who can help us incorporate those things into practice. And so just remember, your fellowship is a launching pad. Whatever you've learned now, in 5 years and 10 years down the road, be ready to learn something new, be ready to revise kind of your techniques and the way you do things, and get involved in committees and organizations so you can stay at the forefront of a lot of these things.
I think that's a great way to end it, since we're 1 minute over. Kind of thinking, when I started residency, the sleeve wasn't a thing. And so now the sleeve is not only a thing, but the most common surgery we do in the United States. And so evolutions happen pretty intensely. And so Dr. Wilson's point is fundamental to, I think, our careers as surgeons. Thank you all very much for participating this morning. We will have a repeat with new questions by Dr. Marc Neff and Dr. Kamran Samakar this afternoon at 3 p.m. And we look forward to seeing you next month at the beginning of September. Y'all take care.
Well, that was a very interesting video that I think we watched. I'm Marc Neff. I'm a bariatric surgeon in Cherry Hill, New Jersey.
Hi, everyone. I'm Kamran Samakar. I'm a bariatric surgeon in Los Angeles, but actually in Hawaii right now.
I wish I was there. So if
Yeah, that would. Go ahead, Marc.
I was just going to say, if people have questions, you can put them into the chat. We'll read them out loud. Otherwise, Kamran and I will entertain you all with discussions about where we see the future of bariatric surgery.
While you guys write your questions, I would just chime in. I thought that was a great talk, and I think part of the takeaway message and what I personally believe is, as these new modalities come out and new techniques and new medications and new approaches to obesity care, surgeons should really be at the forefront of that conversation. So we are, in a lot of ways, the leaders in obesity care for a long time now. And as different disciplines like endocrinology and internal medicine enter the foray with the newer modalities, as well as GI, I think it's incumbent upon us to not only embrace, but to lead on all of these topics.
Yeah, I couldn't have said that any better. I think that we have to embrace the model of cancer care, that there's a spectrum that we offer to patients, with a comprehensive multidisciplinary evaluation before they come to the operating room with medications and other therapies we can offer them if their obesity recurs, just like their cancer recurs, and that it's up to us to steer the ship. Otherwise, we'll fall behind and just become technicians in this chronic disease. Well, one thing that I thought was rather interesting as I was listening to the webinar was, the remarkable number of endoscopic techniques. I have gotten my obesity boards. I do prescribe medicines, but some of those endoscopic techniques are a bit above what I think I can offer. Do you practice any of those, Cameron?
I've taken a couple courses, and I actually um, early on in my career did a couple pouch revisions using the Overstitch. It used to be, I don't remember the company that owned it back then, but I don't do them now. We are providing. We're recruiting a new faculty member that we've kind of tapped that we want to be able to offer that. Just because as a bariatric surgery program, we don't want to not offer that because our GI partners do. I don't personally I'm not compelled to offer someone an ESG when I can offer them a LSG. Um, but it is something that patients are asking for. And so it's important to be able to have the conversation with them.
Yeah, I would agree. I haven't pursued it, and we just hired a new surgeon ourselves, and that was important as we were looking at CVs that were coming to us and interviewing candidates. Did they have comfort level with performing endoscopic procedures? Because we really should be able to offer them the full spectrum of care rather than referring them outside of our program to somebody else to do their balloon or do their management of their leak, or somebody who can perform some of these newer endoscopic sleeve gastroplasties.
Yeah, absolutely. And when I looked at those numbers for last year, there's a lot of talk about both SADI and ESG. In the United States, only about 1,000 of each have been done in the last year's numbers. So I think the just to put things in perspective, the amount of conversation you hear about it is not reflective of the actual volume that's actually being done.
Very well said. Yes, agreed. Really agreed. It's like politics. A lot of things said that aren't exactly what we want to hear.
Right.
Yeah, I was also interested in, the discussion about magnets. I've heard about magnets for years and years and years. I've never had the chance to use them. I can remember being introduced to them for colon anastomoses, and it seems like that's having a little bit of a resurgence.
Yeah, I've seen the Michel Gagne and uh, device. I've never used it. Um, remains to be seen if there's an actual benefit to that approach. Um, clearly, I think bariatric surgeons are pretty innovative. I think a lot of people that go into MIS and bariatrics like the technical aspects of the specialty. And so if they're, on all of these things, what I'll consistently say to residents and trainees is let the data drive the decision making. And so I think that's important that we stay true to the fact that evidence-based medicine, right? So the further away we move from potential advantages, uh, theoretical advantages, marketing preferences, the more we deviate from the core tenets of practicing medicine.
Yes, very well said. I like the past president's comment about, how many of these endoscopic procedures, they're not durable, but they're repeatable, um, which creates lots of billing opportunities for these companies that are coming out with these devices.
I did see a question somewhere. I don't know how to find it. Oh, in the Q&A. Our routine, this is from Sultan Al-Mualim. Our routine, uh, I'm assuming first try MBS cases done robotically in the US, thoughts about benefits and future perspectives. I don't think the uh, primary bariatric surgeries are predominantly done robotically. I think that is the largest growing category of I think robotic, one of the largest robotic uh, surgeries being converted from laparoscopic currently, but I still think that laparoscopic is the dominant approach. I don't personally find that it's useful. I work with fellows and residents, and so there's two people at the bedside. I think my partners in the community find the robotic approach useful because they're a better first assist than they could find in a trained RNFNA or otherwise. And there's no advantages in the literature to robotic approach for bariatric surgery. So I don't use that modality, but I don't think there's any downside to it.
Yeah, I wouldn't disagree. I think this is a really hot topic where people who are coming out are so much more comfortable with a robot than us older surgeons, and they're so anxious to use it on so many different procedures. But is there really a benefit to the patients, and benefit to the hospital in terms of cost, benefit to the patients in terms of clinical outcomes? What I have noted myself, because I've dabbled with these, is that my back hurts a whole lot less BMI 50 and over when I do a procedure with a robot than if I don't. And there certainly is something to be said for physician longevity. Well, this was a topic back in 2023 where they had a point counterpoint at the conference, and Dr. Rosenthal, who, for those of you who don't know his name, you'll learn it. He was very aggressive that you don't need a robot to do any of these surgeries. But his debater was saying, but I'm going to last longer than you, Dr. Rosenthal, because I'm not going to break my body doing these surgeries.
Fair enough. I think if it's another tool in the armamentarium.
Yes, and I think that whole concept of it being another tool is something that you really have to embrace throughout your fellowship training. Don't turn a side eye to anything. Learn about it, read about it. The surgeries you practice today will not exactly be the medicine that you're practicing in 20 years, and you want to learn as much as you can during this fellowship experience. Any parting words of wisdom for our fellows, Kamran? I guess we're almost at the 4 o'clock hour. Wisdom for their first year as they embark upon this training. I guess my words of wisdom to all of you would be enjoy this adventure that you're embarking on. The future for bariatric surgeons is very bright. There are lots of great things coming in our future. Surgical volume will only increase for us, and medicines will not replace us. And learn as much as you can so that you can be doing this for the next 30 years on this planet.
See
Kamran,
you guys next time.
yes.
Thanks, Marc.